Hi, this is Elliot Fishman, and welcome to our latest set of talks, and this is going to be on hematuria. Hematuria is one of the most common things we do in CT, whether it's referrals from the ER or from the urologist or from the GP. It's something we do lots of, and I want to take a practical approach. Now, what I also want to do is maybe take a little bit of a step backward and look at hematuria not so much from an imaging perspective, but from a clinical perspective. This is a statement from the American Urologic Association. Hematuria is defined as the presence of red blood cells in the urine. When it's visible to the patient, it's termed gross hematuria and usually alarming to the patient. Microscopic hematuria is that detected by the dipstick method or microscopic examination of the urinary sediment. Now, when you talk about macroscopic hematuria, again, there's a range of causes. Obviously, what we worry about is an underlying cancer, but anywhere from stones to inflammatory disease. 30% of patients presenting with painless hematuria are found to have a malignancy, but that's typically in the older population. But it is true there's a high risk in the young population. We're going to speak about macroscopic versus microscopic, but macroscopic is really the most concerning. In this article by Hicks, they make the point that, of course, these patients can be managed in the outpatient setting, not so much in the inpatient setting or the ER setting. In that same article, they state that in men aged over 60, the positive predictive value of macroscopic hematuria for malignancy is 22%, and in women of the same age, it's 8.3%. In terms of the need for follow-up investigation, a single episode of hematuria is equally important as recurrent episodes. So gross hematuria that goes away on its own, unless you knew the patient passed a stone, do not assume it's nothing. You still have to evaluate the patient. When you look at the differential diagnosis of macroscopic hematuria, we tend to focus on urinary tract malignancies, be it kidney, the renal pelvis like a TCC, the ureter, the bladder, perhaps the prostate, or the urethra. But there are many other causes: calculi, infection, trauma, BPH, endometriosis, anticoagulant therapy, and many, many others. So it's a very important differential diagnosis. And as I'll show you, CT is excellent at really narrowing down and usually finding the specific cause. When you look at the ACR appropriateness criteria, with 9 being the highest rating, there's no doubt that when you're looking for hematuria, CT is the study of choice. It's a 9. Now, in this other article in urology, again, going back to hematuria, microscopic hematuria or microhematuria is greater than 3 red blood cells per high-powered field on examination of a single specimen. In patients diagnosed with gynecologic or non-malignant GU sources of microscopic hematuria, clinicians should repeat urinalysis following resolution of the GYN or non-malignant cause to make certain you're not missing things. Now, the American Urologic Association also has created a risk classification system with hematuria, stratified as low, intermediate, or high risk for malignancy. Risk groups were based on factors including age, sex, smoking, and other urothelial cancer risk factors, degree and persistence of microhematuria, as well as gross hematuria. Diagnostic evaluation with cystoscopy and upper tract imaging was recommended according to patient risk and involving shared decision-making with the patient. Now, the statements are really pretty good at a way of thinking about things. This is the microhematuria evaluation algorithm, and you could see that risk stratification sitting right in the middle. Is it low risk? Younger patients, women under 50, men under 40, intermediate, women 50 to 59, men 40 to 59, or high risk, over 60. It looks at pack years smoking. It looks at RBCs per high-powered field, whether it's gross or microscopic hematuria, and whether the patient has had any problems before. And you can see with the low-risk patients, you'll repeat the urinalysis, and the high-risk patients, you'll be going with CT and cystoscopy. So it's a very defined pattern. And again, one of the things this article has also made clear is that practice pattern assessments have demonstrated significant deficiencies in the evaluation of patients presenting with hematuria. For example, one study found that less than 50% of patients with hematuria diagnosed in a primary care setting were subsequently referred for urologic evaluation. So I think one of the things that we do need to try to make certain is that everybody understands how the study needs to be done, what the protocol should be, and the patients aren't lost to follow-up. This article makes the point that cystoscopy is underutilized, and again, it's very, very important, particularly if you want to pick up early bladder cancer. And again, here's that AUA, microhematuria risk stratification system. And again, this is microscopic, low, intermediate, high. Obviously, when you have macroscopic hematuria, everybody is in that high-risk category, even a patient who is 30 years of age. Now, in the high-risk category, clinicians should perform cystoscopy and upper tract imaging. Again, that's a CT, multi-phase. We'll speak about that. The importance of CT cannot be underestimated. They do say that if you can't get CT, there's contraindications, then go to MR or perhaps go to ultrasound. But again, CT is surely the way to go. Now, if you look at our practice, and now we're switching from the urologic literature to the radiologic literature, and this article was more than a decade old, but it does make the point because nothing has changed. The most common diagnoses in the ER were renal colic or intestinal obstruction. Now, one of the things we recognize is CT is important in both of these because it altered the lead diagnosis in half the patients, increased physician certainty, and management plan was changed. And we know that that's the reason CT is so valuable in the ER, but with renal colic, with or without hematuria, CT becomes very, very important. Now, in this article by Lotan, the worldwide prevalence and incidence of renal calculi has been increasing, with the number of cases nearly doubled over the last 30 years in the U.S. Acute urolithiasis is diagnosed in about 1% of all yearly ambulatory care visits in both the U.S. and European emergency departments. So we will be doing a lot of CT imaging. The lifetime risk for urinary calculus disease is 12% in men and 6% in women. Personal risk factors include your history, whether you have a urinary tract abnormality, obesity, and metabolic disorders. The incidence for stone disease is highest in the warm regions and during the summer months because of increased rate of dehydration. Remember what your mother told you, drink lots of water. Now, what does the referring clinician really need to know when they send us a patient? Well, is there a stone present? And where is it? The kidney, the urethra, the bladder, or multiple areas? How many stones are there? What's their diameter? Are there additional findings? For example, does the patient have perirenal stranding? Does the patient have acute pyelonephritis? All of those decisions and all of that information leads to the correct decision in managing the patient. Eisner goes on to say, not only does the study enable the detection of stones of all sizes, but in its area of examination from above the kidney to below the bladder base, it enables the evaluation of other urinary and extraurinary abnormalities that may be contributing to symptoms of acute flank pain. And that includes, of course, obstruction. It also includes congenital anomalies. The American Urologic Association and the American College of Radiology recommend low-dose non-contrast CT for the initial presentation of flank pain. Now, of course, we do make the point always that you need to be careful with non-contrast CTs. We 100% agree with the AUA and the ACR that it's the right study if you're looking for stone disease. But in a patient with hematuria, particularly macroscopic hematuria, if you don't see a stone, it does not mean you don't have pathology. It just means you don't see a stone. Now, if you look for accuracy for detecting stones, you can see CT is well above 98%. So it's really the study of choice for picking up stone disease. There's no doubt about it. And you can see the other techniques, but nothing comes close to CT in terms of speed and accuracy and patient comfort. Just really perfect. Now, CT can also be used in management. When will a stone pass? It depends on size and location. 48% for proximal versus 75% for distal stones. And size becomes a big factor. If a stone is over 7 millimeters, the likelihood of it passing is relatively small. So stones 6 millimeters or less are likely to pass, not always, but probably in the high 70s. When you look at stones, we talk about obstruction proximal, mid, and distal ureter. And here's just some examples. And again, even non-contrast CT can follow the dilated ureter to show you where the stone is and show you exactly the length of obstruction. Now, in this article by Lotan, again, one of the other things they found that stones that were greater than 6.5, remember I said 7. Okay, well, the reality is 6 or less, they're probably going to pass. Nobody measures a stone at 6.5. Your calibers aren't good enough. They also made the point that stones, when you measure the density, if it measures over 1,100 Hounsfield units, regardless of its size, that stone is unlikely to pass. So size and density are two factors you should tell the referring physician. The same article, our results showed that larger stone size, higher density, and proximal location are significantly associated with the selection of interventional over conservative management. Complaints of shivering, fever, leukocytosis also strongly correlate with the selection of interventional treatment. And none of that is very surprising. We'd like to do nothing and have the stone pass, but sometimes that's just not going to work. Now the question is, can renal calculi be missed on CT? If you have thick sections, if you don't look at the coronals, I guess it can. But 99% of stones will be detected. We do talk about 1% of pure matrix stones or stones composed of indivar, but that more is a theoretical thing. The reality is, if a stone is there and it's significant enough to cause any symptoms at all, we are going to see it. Here's just a nice example. There's a stone in the patient's left ureter, shown nicely on the coronal. I think one thing about the coronals is not so much the detection of stones, but where are they? Remember, sometimes, particularly in the pelvis, you have phleboliths, you have calcified nodes. But here you can see it, you say, is it in the ureter? You look at the coronal view, it's obviously in the ureter. Or in this case, you have contrast, the patient had back pain. In fact, I think it was done for ruling out dissection, but you see the delayed function in the right kidney compared to the left, persistent cortical medullary differentiation, there's hydronephrosis, and then you track it downward and there's a stone present here. Now, you want to look carefully at multiple calcifications because there could be 2 stones present. There could be bilateral stones, unlikely. But again, stones versus phleboliths, and here you can see the stone present very nicely. So again, it's just a matter of looking at the images, and then you go back, you do some reconstructions, and sometimes the sagittals are really nice, showing you the ureter, and there's the stone. Okay, very nicely shown. So most of the time, obviously the axials alone are good enough, but we always look at coronals and sagittals, and often the sagittals or coronals will give you one very nice image that you can send to the referring physician. Now, in patients with stone disease, you may also see pyelonephritis, but I'm bringing up pyelonephritis as a connection, but also to make the point that Pilo is one of the causes of hematuria. CT is very good for Pilo. Pilo is often undiagnosed or delayed diagnosis clinically, particularly in the ER setting. Now with Pilo, some basic facts. It's more common in women. It's usually due to E. coli infection. In most cases, CT imaging is not necessary unless you're expecting complications. And this is more frequent in diabetic patients, in elderly patients, or in immunosuppressed patients. So again, you need to be thinking not every patient needs a CT scan. Presentation, hematuria is one of the presentations. Classic fever, chills, flank pain are all things we will think about. In renal infection, what do we see? Changes in the renal contour. The kidney will be large. Even on non-contrast, the attenuation may be different than the contralateral kidney. It may be lower attenuation. When you give contrast, it's typically lower attenuation, delayed nephrogram, delayed excretion of contrast, and very common perirenal or perinephric abnormalities. Here's a simple example, flank pain, non-contrast scan. The left kidney is larger. There's stranding around the kidney. There's fullness in the pelvis. And then you give IV contrast and look at the patchy enhancement. Now, when you see patchy enhancement in your mind, you can also think about renal infarcts. Sometimes it's a challenge. It looks very similar. You can think about a tumor. Tumor gives you low density. You can think about trauma and contusion with the right history. But this appearance, decreased attenuation, may be diffuse, may be focal. Perirenal stranding is wonderful for pyelonephritis. Here it is really nicely on the coronal views. So you can see it early. Now, one of the things, if you ask me what's the best phase, if I only had one phase for detecting Pilo, I would say excretory phase. Remember the stratification, all of that written by Bosniak way back when in IVPs, really refers to late phase imaging when there's excretion of contrast. But the best phase is not the only phase where you can see things. Now, I will say that at times, particularly with subtle pyelonephritis, on early phase imaging, you may not see it, and it may be only seen on late phase imaging. But here, as we go to venous phase, the patchy enhancement's nicely seen, and you go to excretory phase, and that patchy decreased attenuation also very nicely shown. Another patient, FUO, left kidney is large, there's some stranding near the left kidney. You go to arterial phase and then venous phase imaging, and you can see the patchy enhancement in the patient's left kidney, the stranding around the kidney, very classic for pyelonephritis. In this case, it's very focal. Could you think about a tumor like a TCC? I guess you can think about it, but it doesn't look like that. This is really the classic appearance of acute pyelonephritis, and here it is on excretory phase imaging. So we will make the point, of course, just to reinforce that patients with pyelonephritis can have mass effect, and this is a nice example of having mass effect present. Again, very nicely shown. The kidney excretes contrast, but that delayed patchy enhancement is really classic for pyelonephritis. Another patient with sickle cell disease and hematuria. The patient also had back pain. Well, if you look, there's a difference in enhancement between the two kidneys. The left kidney has patchy enhancement, decreased attenuation, stranding around the kidney. The left kidney is larger than the right kidney. All the findings we talk about in acute pyelonephritis, you can see it very nicely on the coronal view. The upper 2/3 of the kidney are more involved than the lower 1/3. And again, with 3D imaging, the changes in the cortical medullary differentiation, nicely accentuated. And again, here's just some more images, really giving you a good feel of how you need to look at the images. I think coronal is very helpful. Obviously, I think you should see almost all the infection on the axial views, but coronal can be very helpful. And so just a really nice example, okay? And this was E. coli. Remember, E. coli is very common in sickle cell patients. Another example, a little more subtle left kidney, but I still think you see something, and I think you see it better here. Again, multiple areas of low CT attenuation are indeed possible, which is the case here. It doesn't need to be a single area. You can see how it goes to the periphery of the kidney, and you see it on the delayed phase imaging. One of the challenges at times, if you have too late of a delayed phase imaging, the contrast is too dense in the calyces and gives a beam hardening artifact. You want to make certain you don't confuse beam hardening artifact with patchy decreased attenuation due to pyelonephritis. Now, going back to a point, when I speak about non-contrast CT, we do say it's great for stone disease, but remember, non-contrast CT misses small renal tumors when they don't change the outline. It misses vascular pathology like AVMs, but also can miss pyelonephritis. Yes, if the kidney's large. Yes, if the kidney's edematous. Yes, if the kidney involves the perirenal space, then you will be successful in the non-contrast scans, but you will miss a lot of cases of pyelonephritis if you only have non-contrast CT. Now, why don't we do this? I think it's getting late in this talk. Let's come back and pick up a little bit more on the discussion about non-contrast CT, and we'll see you in a few minutes. Be right back, guys. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.